Mike, I'd like to thank you and also the British Society for the History of Medicine for asking me to give, or inviting me to give this talk. I've used the title, The Mechanics of Science, or How Orthopaedic Surgery and Engineering Goes Step in Step. In the early part of the 20th century, Arbuthnot Lane in London was the first surgeon to use metalwork in any quantity when treating lower limb fractures. Lane persevered in his endeavours in the face of fierce criticism for turning closed injuries into open injuries and because of the overwhelming risk of infection. However, Lane persisted and laid the foundation for inserting metalwork into clean tissue. In this paper, I should like to discuss how the relationship between surgeons and engineers advanced over the years, how implant surgery became possible primarily due to the control of surgical site infections by clean air systems and antibiotics, as well as the ready availability of blood transfusion, along with the improvement of anesthesia and enhanced imaging technology. I would like to use total joint arthroplasty as the model on which to develop this narrative. In 1938, Philip Wilde, an orthopaedic surgeon at the Middlesex Hospital in London, was the first surgeon to insert a total hip arthroplasty into a patient. This implant was a metal-on-metal prosthesis which was attached to the femoral shaft. Wilde operated on 6 patients who had severe rheumatoid arthritis. He published his results 20 years later, saying there was a measure of success in that those who were previously bedridden were thereby enabled just to walk. One patient retained their prosthesis until 1975, and as can be seen, the femoral head metal head has completely worn away. Other methods were used to cover the femoral head using mould arthroplasties, and this was introduced in the early parts of the 20th century by Maurice Smith-Peterson at Boston, USA, initially using glass, then steel, then finally chrome cobalt alloy, and the method became standard treatment for treating osteoarthritis of the hip. The concept of replacing the femoral head remained a challenge, and in 1946 the Judet brothers from Paris inserted acrylic femoral heads with short stems in over 600 patients. Unfortunately, their results were a total disaster as the acrylic disintegrated, partly because of the short stem, which followed the axis of the femoral neck rather than the bony canal of the femur. In the 1940s, Austin Moore from South Carolina developed a monoblock femoral implant inserted into the femoral canal, and later, in 1950, Frederick Thompson from New York developed a femoral stem from chrome cobalt alloy, which was widely used for treating femoral neck fractures. However, committed surgeons persisted in the design of a total hip arthroplasty, and in the UK, George Kenneth McKee from Norwich, who had trained with under Philip Wilde, worked with his orthopaedic colleague Watson Farrow to develop a metal-on-metal prosthesis. McKee enlisted the help of D.H. McCracken, an engineer in the Norwich City Council Engineering Department, in order to develop moulds for his design of total hip arthroplasty, the first being inserted in a patient in 1951. This total hip arthroplasty was based on the Thompson femoral design, with metal on metal. The acetabular cup was fixed into bone with screws, and was later supplemented by acrylic bone cement. Sir John Charnley from Wrightington pioneered the low-friction arthroplasty, the use of high molecular weight polyethylene, small femoral head, and bone cement for treating osteoarthritis of the hip, published his results in 1961. John Charnley was a self-taught engineer, but he was supported by a really capable technician. Charnley collaborated with engineers and had studied lubrication of joints. He was actively involved in research, in clinical research and basic research, and in education, and in the training of surgeons. And he was awarded his GSE by Manchester University in 1964 and later elected to the Fellow of the Royal Society in 1975 and made a Knight Bachelor in 1977. In Wrightington, in the 60s, Charnley established a mechanical workshop where there was a drilling machine and a blacksmith's forge, making both his implants and also the instruments he used in his operation. Harry Craven was Charnley's technician. He had served an apprenticeship at Wigan College of Mining Technology. The story behind the development of high-density polyethylene, the plastic used in the acetabular component, is fascinating. In 1962, a new material originating from Germany was brought to Harry Craven by a salesman, V.C. Binns, who had been trying to sell this material to the hospital supply officer as a new material for plastic gears. The supplies officer phoned Craven, and he saw the salesman. At this time, Charnley was having severe problems with the breakdown of Teflon, the material that he was using for total hip arthroplasty, and a number of his patients were needing revision. Charnley was due to fly to Switzerland at that moment to see his friend Maurice Muller. He was totally unimpressed in yet another new material. However, Harry Craven, in Charnley's absence, continued working on the high-density polyethylene and found there was hardly any wear in the material over a long period of time. On his return, Charnley immediately saw the possibilities. He undertook self-experimentation. He inserted a piece of high molecular weight polyethylene into his own thigh, which he left it there for 6 months to see if it did produce any tissue reaction. Charnley then started inserting the acetabular cups with high molecular weight polyethylene and inserting them into patients. It took 45 minutes for them to fashion an acetabular cup in his own workshop and then insert it into a patient. Charnley also explored the possibility of using bone cement in hip arthroplasty, working with Dennis Smith, a material scientist at Dental School of Manchester University. Polymethyl methacrylate cement had been used in dentistry, and Edward Habush from the Hospital of Bone and Joint Surgery in New York had discussed using it as early as 1953. Charnley approached a local company making dental cement, CMW, or calculated molecular weight. And he also developed a close working relationship with Charles Thackeray, the manufacturers who were making his instruments and now produce his prostheses. Charnley was also concerned about infections and had potential disasters for joint replacement and was running around 10%. Again, with the assistance of Harry Craven, in 1962, Charnley built the first enclosure for the operating theatre at Wrightington, known as the greenhouse, for producing an airflow of one direction to reduce turbulence. As he had done with CMW and Thackeray companies, Charnley worked closely with Howarth Air Technology and with its chairman, an engineer, F.W. Howarth, to produce an ultra-clean air system. The Howarth Company had been established in 1858 and worked on clean air systems, especially for the brewing industry. The commercially available clean air systems later produced vertical flow to reduce turbulence and to eliminate debris. The surgeons wore a bodysuit which involved a hooded system and was combined with an exhaust system exiting from the gowned surgeon, removing debris with carrying bacteria out of the theatre area, as was shown yesterday by Brown Rhodes. Furthermore, Charnley specified that the prosthesis was to be cheap and reliable, at least for the undemanding patients and within the context of the National Health Service. He also stated that neither surgeon or engineers will ever make an artificial hip joint which will last 30 years and enable the patient to play football. Well, there's Andy Murray playing international tennis now. He did not patent his design at the beginning, only later, when there were many copies being made of it in the United States. Charlie had views on the success of the procedure. He said, "British patients are loyal and disciplined, and whatever the surgeon may say tends automatically to be correct. And the resident rarely tells the surgeon absolutely all the truth. The ultimate test of a newly developed mechanical operation is for the inventor to try it out on a neurotic private patient and himself be the house surgeon throughout." Charlie was a true innovator, working with his technician and then developing close links with manufacturers such as CMW, Thackeray and Howarth. Charlie, though, kept complete control of the prosthetic design and the clean air systems. He was the driving force, not the manufacturers. However, this has moved on. Modification of total hip arthroplasty continued, and J.N. Wilson, an orthopaedic surgeon who collaborated with John Scales, a surgeon and engineer, working together at Royal National Orthopaedic Hospital and Institute of Orthopaedics in London. They studied the use of various materials, including plastics, and built hip joint simulators. This was a combined engineer-surgeon team backed by an academic institute producing a total hip arthroplasty. They explored the process of prosthetic loosening. They developed a chrome cobalt implant and worked closely with the manufacturing company Zimmer to improve the prosthesis. John Scales was instrumental in establishing the concept of the biomedical engineer. This understanding of total joint arthroplasty based on Charlie's concept was developed further using improved cementation techniques by the extra group led by the orthopaedic surgeon Robin Ling and with his colleague, an academic engineer, Clive Lee. Clive Lee is an engineer who had worked with Rolls-Royce and after obtaining his PhD joined the academic department of Exeter University. Ling and Lee built up a close working relationship using and developing Charlie's original concepts and designs. They created close links with the manufacturing company Hymedica, who were also involved in changes in the design of the implant. Today, the concept of surface replacement is paramount. It has been developed by the application of science, improved imaging, and industry. One of the most successful of these replacements has been the Birmingham hip developed by the orthopaedic surgeon Derek McMinn, and the company that produced that implant has now been brought out by Smith & Nephew. I should now like to explore the relationship between orthopaedic surgery and engineering and technology and science, particularly to understand the total hip joint revolution. In the Welcome Witness seminars, edited by Tilly Tansey and Louise Reynolds and published in 2006, Sir Rodney Sweetnam, who had been president of the Royal College of Surgeons of England, stated that innovations for total hip arthroplasty came from part-time NHS consultants working in district general hospitals. They were innovative ideas by British surgeons, material scientists and engineers. Charlie had despaired of working with academic engineers. He said academic engineering departments are only prepared to give spare time help from a junior lecturer whose work is often overshadowed by the preparation of his own thesis. In contrast, others remarked that there was a tendency for the engineer to feel a stooge for the surgeon. And indeed, Sir Herbert Seddon, Professor of Orthopaedic Surgery at the Institute of Orthopaedics in London, stated that we cannot be ruled by engineers. One of the problems is what really is the relationship between a technician, an engineer and a surgeon. Stephen Shapin wrote in his paper, The Invisible Technician, stated that servants might make machines work, but they do not make knowledge. However, Shapin noted that technicians are scientists too, and although science is seen as thought rather than work, so who does the work in an innovation? Harry Craven certainly did the work. Karl Popper, writing about science or knowledge, stated that science relies heavily on common sense, saying one might be tempted to say that science is nothing but enlightened and responsible common sense, broadened by imaginative, critical thinking. In Charnley's case, this was so. He did a lot of the work, he used common sense, and he used critical thinking, but so did Craven. But Charnley only referred to Harry Craven once, when in his paper in 1964, he acknowledged him for constructing the operating enclosure for the clean air system. Orthopaedic surgeons initially worked with technicians and then collaborated with academic biomedical engineers such as Scales and Lee, and many coming from the aerospace industry and Rolls-Royce, but are now a fully established independent discipline. To date, the direction of travel is from the orthopaedic surgeon working with a technician, to the orthopaedic surgeon working with a bioengineer, to the orthopaedic surgeon and bioengineer working with manufacturing companies. The future may well be industry employing orthopaedic surgeons to use their product in their hospital with their outcomes, and the company will undertake the research. So, for example, Pfizer, who owned Harmedica, could employ orthopaedic surgeons in a Pfizer hospital to use Harmedica designed implants to receive Pfizer antibiotics, anesthetic agents, and other drugs. The implants will be developed by the company's bioengineers with clinical input from the orthopaedic surgeon. This seems a real possibility because of the demand for resources, control, and experimentation, all of which can be provided by big science and funded by big pharmacological companies. John Pixton, in The Ways of Knowing, discusses the role of technoscience. This is the growth of technoscientific companies producing new commodities from their own research laboratories and also from the web of academic and government laboratories. Pixton argues that this will now increase in order to use the best use of resources. This is part of the process of modernisation as explained by Casper and Welsh, that there is centralisation, regulation, specialisation and standardisation. And these are all now important factors in today's markets. The relationship between the surgeon and engineer has therefore come a long way from the original individual surgeon working in the face of controversy, such as Buffnet Lane. Also, in order to ensure compliance with these techniques, Charnley, for example, advocated strongly specialisation, but he also stated in his manual in 1975, the Thackeray Manual, that implants would only be available to men who have worked with me at Wrightington for a period of 6 months or more. He also envisaged two types of surgeons: those who got first-class degrees and went on to become professors and teach, and those who got second-class degrees who will be trained to a high level of technological competence in a narrow specialty such as total hip arthroplasty. But there remains the romantic idea of generalism, of a need to be able to see across disciplines and to benefit from cross-fertilization for, in this case, bioengineering and bioscience. But underneath it all, the surgeon's real contribution is that he or she is doing their best to treat the patient, or in this case with a painful hip, and it's the surgeon who has to remain independent. Thomas Kuhn, writing about scientific revolution, describes the process as pre-science, normal science, crisis, revolution, new norm, then new normal science, the new crisis, and the total hip arthroplasty revolution certainly follows this. Pre-science, the need for a total hip replacement, and early designs by Philip Wild with no experimentation whatsoever. Normal science with studies of joint lubrication and low friction by Charnley, then new materials by Scales and others, based on experimentation and the application of these experimentation research concepts into patients. Crisis, then the near disaster from Julia Brothers acrylic and also from Teflon. And then the anomalies occur and they lead to new scientific discoveries. Charnley's discovery certainly was a response to a crisis, and with the introduction of high molecular weight polyethylene, it was indeed an anomaly how it occurred. And this leads to a total hip arthroplasty revolution, as is now practiced, and new normal science, with further development of materials and plastics and a fundamental change in design by Mins and others, and the measurement of patient outcomes along with the involvement of business. The new crisis is perhaps waiting for patients' expectations, demand for revisions, the universality application of total hip arthroplasty, beyond Charnley's original concepts, way beyond, and leading to a new revolution from perhaps another observation or another anomaly. Chairman, at the moment, the engineer and the surgeon work together in a partnership. The future may well be different. The individual surgeon who designs and develops an implant in collaboration with the independent bioengineer or bioscientist will, I believe, make the most important contributions. But they must be equal, and in today's environment, they need access to business skills. Charnley's original idea of a cheap prosthesis readily available for the elderly patient within the NHS has a lot to recommend it. But it is no longer the main aim, as the design and the materials used in total hip arthroplasty are widely available to surgeons, engineers, industry, and are being applied even to the temporomandibular joint. Moreover, as industry is involved, new implants are being designed to stimulate the market, not necessarily just for the patient's practice. So the challenges are therefore really enormous. But without access to real resources to fund future designs, produce scientific evidence to satisfy regulatory bodies, along with records of long-term outcomes, the individual innovative surgeon will make little headway. But knowledge or science does progress. And as Thomas Kuhn wrote, it is often not sequential, but by occasional episodes of serendipity, as in Charnley's case, or even potentially by anarchy, as James C. Scott observed in his book, Two Cheers for Anarchism. It is part of our human nature to shun narrow uniformity in favour of variety and diversity. Chairman, what is of concern is that the orthopaedic surgeon could become the technician. And unless orthopaedic surgeons broaden their knowledge, particularly in the relevant disciplines of bioengineering and bioscience, they will become the workers, or a Charnley's second-class degree surgeon, or indeed Shapen's forgotten technician. But what is unique to surgeons is that they are actually treating the individual with the resources and support that he or she have available, notably from the bioengineer, in order to develop new methods for managing these conditions that affect patients. Thank you.